TopMedTalk.
I'm Vicki Morton. Thank you so much for joining us. I actually am a nurse practitioner, and I function as a director of clinical and quality outcomes for a hospital system and oversee and run our enhanced recovery after surgery program in 9 hospitals. So really excited to talk about this perioperative care team. With us, we have Dennie Levett. And Dennie, could you introduce yourself, please?
Yeah, hi, my name's Dennie Levett. I'm a consultant in perioperative medicine and critical care and a professor in Southampton in the south of the UK. My clinical job is that I lead the perioperative medicine service, and I also lead the surgical elective high dependency postoperative unit. And my research interests are very much in identifying and preparing the high risk surgical patient for major elective surgery. I'm interested in exercise testing and risk stratification and perioperative optimization.
I'm going to go ahead and introduce Gina.
Can you hear me? Yes, I'm Gina McConnell. I'm a nurse out of WakeMed in Raleigh, North Carolina, and I'm the ERAS coordinator there. I was part of the team that implemented the cardiac surgery protocol back in 2017.
So the purpose of today's session, the perioperative care team, here at EBPOM, we just want to, include everybody in the perioperative care team. So when people hear that, they sometimes think surgeon, anesthesiologist, nurse, but there's so many other people that need to be a part of our team to make it successful. Dennie, can you talk to us a little bit about what does a perioperative care team look like over in London?
One of the things to say is I can certainly tell you what our team looks like in Southampton, but even within the UK, although we maybe have started this journey a little ahead of the US in thinking of more integrated care across the whole surgical pathway, there's a lot of variability in terms of different centres. So in Southampton, which is where I work, we have a perioperative medicine subspecialty, and within that we have 5 consultants anaesthetists, and of those consultant anesthesiologists, as you would say, half of those are actually intensivists as well, so we have shared job plans, and we don't do this full time, so all of us do other clinical specialties. We have a consultant geriatrician who works with us a day a week, and then we also work closely with all of the consultant surgeons, but none of them actually have a full day of perioperative medicine in their job plan. So that's the doctor bit of the team. Then our service is led with lots of AHPs, we call them, so allied health professionals. We have a senior nurse manager who oversees all perioperative medicine service and the prehabilitation service and the cardiopulmonary exercise testing service. And we have 3 other full-time nurses beneath her, one of whom whose lead is the high-risk clinic, one whose lead area is perioperative anemia. We have about 15 nurses in preoperative assessment, which is more at the last, that's for preparing a clinic we run where all patients are seen immediately prior to surgery. But we separate that slightly from the perioperative medicine service, where we see patients at the point of contemplation of surgery. So when I think of the perioperative care team, we think there's the point where we think about surgery, and then there's a period before they get to have, go and have that surgery and the dates given. And in that period, we're talking about anemia optimization, diabetic optimization, and prehabilitation, exercise, nutritional optimization. So we have a dietitian in the team as well, physiotherapist. We have 3 exercise physiologists, and that makes up our MDT. So you can see it's a pretty large team and it's reasonably complex. Most of the dietitian we have a day a week, but it's going up to 2 days a week because there's a huge amount of unmet need we found preoperatively if you see patients early enough in terms of nutritional optimization. And then postoperatively, we have the enhanced recovery team as well, but they're reasonably separate from us, except we all work very closely. We run a surgery school, which was prior to COVID, face-to-face patient and relative education, but now is done virtually.
Kay Mitchell, I did not have you introduce yourself. Could you just say a little bit about, where you work and what you do and give us an idea as to what your perioperative care team looks like?
So I actually work with Dennie at Southampton. I'm more on the periphery. So I've done some cardiopulmonary exercise testing in the past, and I've worked within perioperative medicine, but a lot of the work that I do with the perioperative team at Southampton and across the wider network is about trying to encourage nurses, midwives and allied health professionals to get involved with research related to perioperative medicine. So there are 2 or 3 of our nurses and allied health professionals based at Southampton who are pursuing research alongside their clinical role. So the senior manager that Dennie mentioned is one of my mentees. We're trying to develop that whole multidisciplinary research aspect. So that's really what my background is. I'm a critical care nurse, and I spend a lot of time trying to help support other people to do research into making care better for patients.
Gina, could you just let us know what things are looking like by you in Raleigh, North Carolina?
Yes. Well, we're hanging in there like everyone else. I would say we do not have the resources that our friends just mentioned in Raleigh, North Carolina. We've struggled with that, just not having those resources. But our team definitely, I think you hit it right on the head, Vicki. We need to be able to, instead of being siloed, we need to share everything that we're all doing and ideas and work with each other and learn from each other. But we started off with a very small team. It just consisted of the surgeon, anesthesiologist, nurse, pharmacist, kind of like Vicki referred to. But we quickly learned that we needed the entire perioperative team, and we brought in those forces quickly. And I think we really just had to manage them up, empower them to understand the benefits of ERAS. That core team understood the components of ERAS, but not our complete perioperative team. We have been attempting to have a strong Prehab program, and that is really what we're focusing on. And now we've embedded a teleheart virtual. So our entire perioperative care is going to be as much face-to-face, but we honestly know we're not going to be able to do that as well. So we have people embedded in all the areas that was just spoken as well. We just lack those resources. The biggest challenge is trying to get all of them on the same page and then keep them motivated to be on the team, to see the results, to empower them to continue even when that core team isn't directing them. We need the entire. So it is a challenge.
Yeah, so you bring up a good point, Gina, keeping them motivated and interested. And I know that for us in our system, that can be a struggle as well. I'm just trying to figure out how the approach is so different. And it seems like you have such a large engaged team. What can you tell us to do maybe that might help us?
So I think some of the challenges that are different in the 2 healthcare environments reflect the funding environments as well, because the fee for service, in order for you to develop a funding model for something that's not in there, reducing cost isn't a great way to get funding to support a new service, as I understand it from speaking to Phil and others, because you get a tariff each time you do an operation, and there's a much faster throughput. There's always swings and roundabouts. One of the advantages of having a nationalized health system is that we are all very focused on reducing length of stay, and although you're moving more to that system in the States, improving efficiency and avoiding what we would call wrong patient surgery. So doing an operation which actually ends up harming a patient and there's no benefit. After all, patients come to us for an operation either to improve their quality of life or to live longer. And if you end up with a patient who's having a quality of life improving operation like a knee replacement, and actually they end up worse off than where they started because of complications of surgery, because of lots of comorbidity, then that's a disaster for everybody. And not only is it a disaster for that individual, it's a disaster for the healthcare system because they're in hospital for a long time. And for us, that means a massive cost to the one payer. It's not that if they stay in hospital longer, they accrue more money, if you see what I mean. We only get the way the tariffs are set up, whether you spend 40 days in hospital for a hip replacement or 5, your hospital gets the same funding. So it's a major incentive, I think. So that's one thing that, obviously we can't change across systems. But I think in order getting the funding, understanding what the drivers are is really important. And then I think within actual individuals and with the team keeping them motivated, the prize is really a happy patient. And I think one of the most powerful tools we have is patient stories. And I actually think those also go a long way to persuading people in positions that can give you budget. They're much more powerful often than lots of data. So there's two things. There's patient stories, individual stories, and then secondly, there's collecting data. And I know it sounds like we have loads of people involved, but, only 6 years ago, not so much from ERAS. I mean, that's sort of an accepted practice. It's meant to be accepted national practice in the UK, and it has been for some time now. So in a way, that battle had been won to some extent. But to move into the preoperative space, that's been a new position. 5 years ago, we had no service in Southampton. So what we started off in a small group of patients, using as case histories the patients that we all know about that certainly in the UK sometimes turn up. So, for example, we look at esophageal cancer patient. So the standard of care now is that you have neoadjuvant chemoradiotherapy and then you have a procedure. So even in a healthcare system such as yours, where there isn't much in the way of waiting times, you find out about a patient, or your health system does, they then go off and have 9 weeks of chemoradiotherapy. They then have 9 weeks to recover, and then they have an esophagectomy. So it's really disappointing to me to discover the week before their esophagectomy, they're morbidly obese, they're still smoking, they're drinking like a fish, their diabetic control is poor, and they're anemic. And we've had, at that point, 3.5 months to do something about it. And I think, those sort of stories are powerful because that patient then went on to have a leak very early and spent 6.5 months in hospital. So a disaster for everybody. So we took some of those high-risk cases and said, if we'd known about this earlier, this is what we could have done. And that's what we started to use to motivate people. And I think sometimes finding a surgeon who's engaged and an anaesthetist who's engaged, a small group of people in a specialty where you think you're pushing against an open door. So in our trust, the really enthusiastic young surgeons who are into ERAS and Prehab happen to be urologists. And that's one of the places we started. And we started with cystectomies. And I think there was a lot of naysaying from other surgeons at the beginning, shall I say, other groups. But what we found is we focused on that small group, and then they improved their length of stay, they reduced it, and their outcomes improved. And then all of their friends were a bit upset that they weren't getting, surgery school and a few of the other things we were offering. And we actually found surgeons trying to sneak patients into surgery school for another specialty. It's a general thing. So we thought it was quite funny to mind. But I think that's one of the ways that we help to motivate people.
Can I also say, I think from the nurse, midwife and allied health professional point of view, what you and Mike and other of your medical colleagues have been very good at is encouraging the whole team to get involved in sharing the data and manipulating the data and bringing forward ideas. So it's actually completely a multidisciplinary team that works together to improve the outcomes. So everybody sees the value of collecting the data and being engaged and contributing to papers. And I think it's that mutual respect and that working together that makes the team effective and means that we have a lot of people that want to work with us. And I noticed that one of our people on the call is Mariette from the Netherlands, who's a nurse who's approached us to do her master's program with us. So she's going to be in the COVID world joining with us virtually. And I think that's credit to Dennie that she's very open to working collaboratively.
And I think clinically, it's handing the problem back to the people that know the pathway and the patients best. Because people, if you say to them, how do you can present them with a problem, but, ask them to find some solutions too. And people, often the nurses who are cancer nurse specialists, which is a nurse that stays with patients all the way through their cancer, but they have lots of ideas. They know what the patients struggle with and when they'd like support and what sort of support they do and don't want. So it's asking them. And then if you give them ownership of that idea and developing the service together, it's much more effective, as Kay says, rather than doing a top-down thing where you try and tell everyone what to do.
Right.
Yeah,
I have
experience. I've tried that and failed.
No, I'd like to tag on to that because I think that is so important. when we first created our ERAS team, we bonded and appeared very strong and equal. We didn't have a hierarchy. And so when our multidisciplinary team saw that, they began to become part of that team. And absolutely what you said, we brought those stories back to the front line. The first thing I think we did really well was we took so long to educate on the exact components of ERAS, preoperatively, intra and post. We talked about their direct implication, what they did directly for that patient and how that output could be affected by that frontline person. But even more so, when we got the data, we didn't just pop it up on a screen or send it an email. We went back to those people and we celebrated. We celebrated the wins. And that is when I felt like our multidisciplinary team grew at its best, because they were all empowered. They thought they knew they were that piece of that puzzle that helped get that patient there. So I absolutely love the storytelling and patient stories. That's been very effective, as well as the data.
For us, our team, we meet once a month. So I said we had 9 hospitals. So each hospital has their own perioperative care team, and everybody comes once a month together. And during that meeting, we do share our data. I have a nurse that works with me. She collects all the data. She's awesome at it. I love her. And then I look at the data and analyze it and then present it to the team. One thing that I have found with our team and our meetings is I don't like it to be just somebody leading the meeting and sitting at a table and just spewing off information. I want to hear from the dietitian. What are they seeing? What challenges are they having? What's working well? What are the patients needing? And that's how we find out that, our patients, they don't like the post-operative protein drink we give them. So, okay, we need to fix that. I want to hear from pharmacy. I want to know ahead of time any drug shortages that we're going to be encountering, and so that we can prepare. What they do is very important. Physical therapy. So we just go around the table and everybody knows that they are going to have to give an update and let us know what they're doing and how is it impacting the patient, so that we as a team can talk about those items and come up with solutions if we need to. The data, I think, is so important, helps with everything. And so completely agree with you. And Kay, I know you talked about research. I think that's an interesting point as well. You guys do a lot more research than we do, I think. Can you speak to that and how does that impact the involvement? And do you find that by having that engagement and the research that does bring other allied health professionals and nurses into the game?
Absolutely. I mean, the NHS in the UK recently produced a document called the NHS 10-year plan. And one of the overwhelming messages coming out of that plan was that we needed to do more for people with long-term conditions to try and improve their outcomes, but also that we needed to engage the multidisciplinary team in trying to work together to improve these outcomes. So there has been more of a drive from our NIHR, which is like your NIH in the States, to encourage the non-medics to actually engage with research. And in particular, they have noticed that our allied health professionals who are our physiotherapists, our dietitians and our occupational therapists are a lot better at getting involved in research than our nurses are. And so what they've done is they've funded this particular program to get 70 nurse leaders across England to actually try and encourage more nurses to get involved in research. And I'm one of those. And so it's about going and lobbying to get funding to buy us time out of our day jobs to actually do the research that matters to patients. And perioperative medicine really kind of fits that well. So the senior manager that Dennie was talking about is currently funded 2.5 days a week to develop a program of research. She'll soon be hopefully starting to do a PhD if she gets the funding for that. And a lot of what we do is try and find pockets of money to actually get people bought out of their day jobs so that they can grow their research expertise. Now, having been in the States at Duke University in January and February, I met up with you, which was lovely. I tried to engage with quite a few nurses in America, and it's quite diverse. Some hospitals seem to be much better at encouraging nurses, midwives and allied health professionals to get involved in research than others do. But I spoke to one senior nurse, I'm embarrassed to say I can't remember who it was, but I think it was someone that you'd connected me with, Vicki, and she was saying that we need to get better at lobbying our senior people within healthcare to support the wider team, because we all have different strengths and we all have different parts of the pathway that we see that we can improve. And research is completely associated with better outcomes for patients, and we retain staff better if we give them research opportunities.
How do we, as a group, engage? Is engagement what people want? Do we want to collaborate and really, maybe regularly meet in some way or another, put together a group that is the perioperative care team, but bring some people along? We would love to see allied health professionals at our EBPOM meetings and really getting involved. And that's the goal here. So what's the best way to do that? How do we engage people to come along with us?
Do you think it would be useful to do something like a monthly journal club?
I do. I know, Kay, you and I had talked about that. I think it was London, London meeting on the call, doing something monthly. And I think a journal club would be really wonderful. Yeah, Kay, I think that's a fantastic idea. But
what would you say is your biggest challenge that you want to know most about, Vicki?
I think that the pre-op optimization piece, our facility, they just don't really see the value. And like Dennie said earlier, right, with payment fee for service, we try to be value-based, but let's be real, right? There's still only so much reimbursement that happens. And so a lot of these patients, unless they meet certain criteria, we don't get reimbursed for their visit. So we struggle with that, and we're not really putting the patient first. Don't know how to change that here in the States. So that is something for me personally in our institution, what I would want to focus on.
So Dennie, my challenge to you is to suggest a couple of articles that we might look at in our first journal club based on what Vicki has just said she's interested in.
To clarify, when you say a journal club, do you mean more looking at primary research, or would we, for example, there has been some useful reviews recently, for example, perioperative nutrition. It may be worth looking at generically overall the information about preoperative exercise and outcomes. I mean, I could point you, it's always easy to point people to research we've recently published, but, Sandy Jack, who's not here, the Empower and the Embrace studies, which are looking at preoperative exercise training in colorectal cancer, Malcolm's paper, the BJA paper, for an exercise testing, I would probably look at the BJS paper from 2014, which is a look at it's a multi-center look at the use of cardiopulmonary exercise testing preoperatively to predict outcome after surgery. Those are both good places to start with, which is a generic. And Chelsea Gillis from Montreal has done a nice systematic review this year about multimodal prehab, looking at an overview of nutrition, all the studies looking at nutrition and exercise preoperatively. But that's probably a good place to start as well.
Okay, thank you. Yeah, so in the chat box, a couple people have weighed in. Sherry Bernardo, she said, I agree, prehab is where we also struggle. And then an individual from Hong Kong, they said, hello, from Hong Kong, we have an issue with shortage of allied health resources or funding to support their role in the area of prehab.
One of the interesting things I also think about prehab is there's been a huge amount of focus the last 5-10 years on exercise. And, I'm an exercise geek. Anybody who knows me knows that. But my PhD is in exercise physiology and on Everest, in fact. But so I'm all for that. But actually, there's a lot of ignoring of the nutrition literature, which is actually already there. So one of the struggles we have, I think, at the moment with exercise prehab is that we haven't got a good prospective randomized controlled trial showing clinical outcome benefit. And, I have to put my hand up. We all must be, cognizant of that. We know that getting patients fitter will improve their longer term health outcomes. Now, that's another challenge to you guys because your system doesn't really focus on that, whereas the NHS is quite worried about the fact we're all getting older. And if we don't stop people getting larger and less fit, we're going to have massive problems in the future storing that up for ourselves. So, we know that exercise is good from that point of view, but is there a good, big, multi-center prospective study yet showing clinical outcome benefit? No, there are several ongoing, and I do think that will help the challenge for the funding circle, because you go round and round in circles at the UK. We all think it's a good idea, but when you ask for funding, they say, show me the randomized control trial, except for when they don't, they want to ignore it and they do social prescribing, and then we're allowed to do that without evidence. But I do think that will help us. And I think hopefully some of Sandy's work, and there's a study going on in colorectal cancer in the north of the UK, a big study, and there's the international prehab study. Hopefully those will provide extra ammunition, because I think that otherwise you just go round and round in a funding circle. But what I would say from the nutrition prehab perspective, and we don't focus in on it so much, but I would say, exercising a patient who's malnourished is a waste of time because it isn't going to work. They won't get better. You need metabolism. We've actually already got good data that says malnourished patients do badly and that preoperative interventions improve outcomes. And we still don't seem to be able to achieve doing it. And actually in the UK, we're behind with that, I would say, too. I think we're good at identifying the hugely cachectic patients, but we're not so good about screening all patients. Paul Wishmar at Duke gives some great talks about this. You can see some of that. But, our local data, when we screened everybody that was coming to our perioperative medicine service, 35% of them on a simple screening tool were at high risk of malnutrition. And of that 35%, only 15% were known to the dietitian services. And our dietitians are all incredibly busy dealing with the aftermath of doing operations on people who started off in a poor nutritional state. And so that's the other thing. It's getting from the stage where all the resources directed post to try and direct some pre, which may eventually reduce what you need post. But you're in that difficult area. But there is data for nutrition, and it always surprises me that the fact that we know that malnourished patients do badly, we still don't manage to address it. And certainly in the UK, we have a problem with not enough dietitians, which is a major issue.
We have that issue as well. That's one of the struggles, whether it's outpatient dietitians or the inpatient dietitians. I think we've got 4 total for the main hospital, and it's a big hospital. One of the attendees said, I wonder if a single intervention like exercise could show outcome benefit. What I think about is a bundle of care. I agree. Like exercise plus nutrition plus cessation of smoking, et cetera. And to Dennie's point and what she just talked about, why exercise a patient who's malnourished? It's not necessarily going to work. It's not going to work. Wow. And so we have to focus on everything, the whole patient. I'm just reminded that our session is going to be ending here in now. But Gina, what was your thought?
I was just going to say, I agree with the bundle. That is exactly what we've been trying to do. We in the United States, many of us, it's not just one single factor. It's no longer like just nutrition or dieting or just exercise. So we've created this bundle. We know what to do. We know all those things to cover. But for us, it's the resources, the funding. How do we bring that in to support what we've created? And I feel like we've just been spinning our wheels because we don't have that. But yeah, the bundle approach is exactly what we were trying to do. I agree with the comment.
Yeah.
So can I make a suggestion, Vicki, that if people,
Sure.
I know we said this in London and we did have people respond to us in London, but I think if we start small with a journal club, as I suggest, it may be that we get people connected and then we can use our power of working together to actually influence for more resources.
Yeah. I think that's a great idea. And I think that's a wonderful way to end our session because we're going to be kicked out if we don't. Dennie, Kay, Gina, myself, we can start with one article and see where it takes us.
Excellent.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.